Actually, this concentration is very similar to Mycobacterium abscessus. We know that amikacin is an effective drug in that setting. Don't have a lot of experience with inhaled medicines. But again, this is a bug that's responded. Amikacin is the drug, honestly, for Mycobacterium abscessus. It is a tough regimen if you cannot use it. So these MICs are exactly in the same range. Makes me believe that these MICs should predict clinical outcome. If we were able to get everybody else to buy into this, this would only be the second drug that would be approved for use with testing of MAC. Let me go back. Again, one of my main troubles with inhaled amikacin was I couldn't test it. Supposing Ken had a patient on it for 6 months, and now comes the question, should I keep going or not? I have a way in the lab to tell him whether or not this isolate, the drug is likely to still be active or the drug is not active. Very important for a drug, any of these drugs, but would only be the second one that we can use. I'm sure that the makers of Arikayce are going to be thrilled, because I think if you had the presence of this mutation, I will bet that that form of inhaled amikacin may not work as well. We know that for other levels of resistance with the same mutation, it's usually resistant to the highest concentration you can test, which is in the past for the other organisms is more than 1,000 micrograms per mil. That is one of the most exciting things that we've done in the lab. It is an example of an old drug listening to your patients, which Philip kept saying, listen to your patients. I didn't agree with the first one, and I'm sad in some ways because she is resistant and I can't use that drug anymore. But she also clearly got better and has stayed better. And the other lady is amazing. She gives me a kiss every time she comes into the office because she's so happy about where she is. Again, it means that the Arikayce trial is incredibly important. The potential for this drug is enormous. Many of the NTM, most of the NTM, have concentrations that are inhibited by amikacin for which you could use inhaled amikacin. The thought, for example, could be added to regimens for which, for example, with MAC, our success rate in making patients negative is maybe 70, 80%. If you added inhaled amikacin and it works like that, 100% of the patients are likely to convert. An enormous step forward using a very old drug. My only other comment here has to do with fingerprinting. You heard already that I think fingerprinting is a very important thing to do. Fingerprinting is where we take the DNA and look at it in a certain way so we can tell you if an organism that you have now is the same as an organism you had in the past or it's different. This is an example of an old technique that we used called pulse field gel electrophoresis, in which pieces of DNA are run on a gel. I always say this looks like a can of beans in your grocery store. You got all these bands on there. In each of these two patients, this was a relapse isolate after the patient had been off drugs for about 3 months. The second one, this patient had been off drug about 4 months. You can see the band pattern is exactly the same. Why is that important? If it's a different organism, then you just give them standard therapy. If it's the same organism and they failed therapy, then Ken and we're going to sit down and we're going to think, now what do we do with this patient? There's no point in doing it again exactly the way we did it before. So often means we add other drugs. We add an injectable drug like streptomycin. We may change from rifampin to micabutin. Those are the standard things we kind of do when we fail therapy. So knowing whether this is a failure, which these two patients are, or it's a brand new organism, has an incredible impact on what I do with the patients. And you certainly want to know, because you're going to get shots in your rear end for the next X number of months, and you're going to take a drug that's likely to make you more sick than I've already made you with the 3 drugs that I've given you, you really want to know about that. And this is a way of doing it. You heard mentioned VNTR. For time reasons, I won't tell you. It is a much simpler way of looking at different isolates to be able to tell you if they're the same or different. We use it in other ways besides this clinically. We are the only lab in the United States that does this. But every time you relapse, one of the questions you want to ask, is this a new bug? Or are my old drugs they just weren't good enough? Nobody can answer that question because nobody does the testing. So one of the goals is to find a relatively easy way to do that so everybody can test it. It does mean they have to save their organisms, which actually is easier than most of them think, and you have to have a technique to do it. I mean, we can't test all the isolates. We need to get other labs to do it. So here's a step that makes an enormous difference. Observed in one lab, it needs to be pushed to other labs to let them be able to measure the same thing. There's no reason that Adrian can't do this, and we'll push him a little bit to do it. It is not that complicated, but very important in terms of what goes on. And my last thing here is, this is something that we need. This is from a paper that was published in 2006, and this was the treatment of sputum samples artificially seeded with M. abscessus, meaning they were sterile before you put the M. abscessus in it, or M. avium by the standard method by which we process sputums, which was developed from TB. We have no special processing for NTM. Since everybody's looking for TB, they just use the method that worked for TB. Well, these are not TB. Some of them are a lot more sensitive to this method, and you can get an idea of, in this setting, when we used the standard method, and they had 10 to the 5th or 10 to the 6th organisms diluted 1 to 10, we'd lost 4 logs of organisms. That's 10,000. That's an enormous drop. And anything below that didn't grow. They did much better with another drug called chlorhexidine, but it's not generally used. It's not as simple to use. Interestingly enough, the drop for MAC wasn't very much. We probably do fine with MAC. But for M. abscessus, if you have 10 to the 3 organisms per mil in your sputum, you are not going to get it. And it makes me feel bad because I may be calling patients negative when they're not negative. And maybe the time to identify patients is early when they have small numbers of organisms as opposed to late when I think disease is much harder to deal with. So it's only to say there are hundreds of issues that may need to be resolved and not many labs that are working on them. More blue blindness. Thank you very much.